everything else. And I think what often happens with training is that we're coming up on a potential release date and someone says, well, let's wait for the next CMAC and let's push it back. And then training doesn't really know when does this really have to be done. So, I would make a motion that the next set of protocols comes out July 1st, is released is in effect, not released, but is in effect July 1st, 2026, and will be in effect July 1st going forward. So I'd make that motion, and then we could make subsequent motions on, approval dates.
Second. All right. So we have a seconded motion that July 1st should be our release date, 2026, and going forward, July 1st should be the date. That's the motion. Any discussion on that? Yeah, I see a hand.
Yeah. So my question would be, if your release date is going to be July, you can't. I don't know that you can make the protocol effective that day. Make the protocol effective that day. They haven't been trained on it yet.
No, I think you need the effective date. Yeah, my motion is for the effective date. And this is I don't say a separate conversation, but I personally am a believer that we should release. I mean, similar to the state, they'll release the protocols, 6 months in advance for people to have time to read them and process them. So that the release, when the public can see them, is, I think, a separate discussion. My motion is that the new protocols go into effect July 1st,
right,
2026, and on July 1st going forward.
Okay.
So
and then you work backwards from there when you release it, when you train.
Okay. Jeff?
Yeah, and I think, right, as was alluded to earlier, how far back you go depends on how much change is there and how much training is involved, right? And you could adjust that to hit an effective date of July 1, and that also aligns with kind of the CMAC schedule and the state release schedule every year. I think we'll have more opportunities to get the approvals we need with less trouble.
Any additional discussion? All right, hearing none. Motion on the table is for the effective date for the protocols to be July 1st, going forward, now and forever.
Who seconded?
It was seconded by Jeff. It was made by Ben, and we can vote on it now. We don't need a roll call vote. It's not a protocol change. It's just an implementation date. So all in favor, please raise your hand. This is for the physicians. 1, 2, 3, 4, 5, 6, 7. Hold on. 16, 17, 18, 19, 20. That's 20. So I think we're good. All right. Any opposed? Any abstentions? All right. Seeing none, it passes unanimously. Thank you. Okay. So anything else, Mr. Lax?
Nope. We will follow REMAC's lead.
Okay. So now let's move on to the CNC and medical standards reports from Dr. Barber.
Sorry for my tardiness. CNC met on October 3rd. Next meeting is November 13th. Topics of discussion. Basically, we're discussing building a free/minimal cost LMS review course as an official reference for people taking the initial exam or for a post-examination failure. This is basically to avoid any compliance issues with the liaison when asked about additional resources for people looking to improve their examination efficacy. We have some volunteers at the credentialing committee to help build this out. Might be something on the LMS. How it looks in the future remains to be seen. But basically, if somebody fails, Kevin has trouble with where to have them referred to, and we want to have something that's on the official site.
Okay. Any questions for Kevin or Paul about this?
Yeah.
I know. We're going to go one at a time. All right. None? All right, Paul, keep going.
All right. Success. Other topics are the use of artificial intelligence to generate questions for the initial exam. We have some content experts in the group that have experience with this from the state level, and we're planning on mirroring the state practice. We also have some people just essentially testing the fences, which is always interesting to see progress born out of initiative. So thank you to those who took the initiative to try this out. Much like any artisan, sounds like the initial phase didn't always work out with the final product. So we're working on some human revisions to the AI generated content, but the focus for the future is not to have AI rewrite the test, but more to facilitate test question writing with the human being the driver, but the content being with the technology being leveraged to reduce human work and futility. Our plan is to have questions that are written by AI reviewed in the exact same method as we review questions for the initial exam in small group with human interaction. We have no computer robots yet, though. We're working on test robots. That was supposed to make fun of people. Last two things, there will be an item analysis of the existing examination as there's enough test takers from various test entry points, I would guess, or the schools, whatever, or education areas. So we can have some item analysis of the exam to prepare for this legislative session, probably by December, January. I think there's still needs to be some review of it, but by the way the meetings go, we plan to have an item analysis. We haven't had one in about a year and a half. And the last thing is effective January 1, 2026, fees for the tests are increasing from $25 to $35. Mr. Ward?
Thank you, summed it up.
Like a computerized robot. Right, that's the CNC report.
All right, thank you. You want to continue with the medical standards report?
There's actually one thing Mr. Ranieri reminded me of. I apologize. Medical control faculty members and those who can give the class is a topic of discussion. We're looking to identify means for the existing REMAC medical control faculty to maintain their faculty credentials through either teaching or quality review. There's a one-page that Dina had written up and we agree with that relates to the responsibilities of being a medical control faculty member for the region. As soon as my phone allows my computer to pull up the email, I can share the content, but it's all the stuff that we discussed already. Those of you in the room who know that you're faculty, I plan on sharing this with you offline so you can continue to maintain your credentials and continue to teach in a punctual setting. That's the CNC report.
Right. Now we'll go medical standards.
Okay. Medical standards report. Medical standards met September 26th. Next meeting is November 7th. I'm sorry, protocol committee met. Protocol committee report, I'll defer to Dr. Lai. I apologize.
I will, oh, sorry. Thank you, Doug. So the first protocol that's coming forward from medical standards will be a language change that is to the current obstructive airway protocol. As you can see on your screen, oops, let me try and make this a little bit bigger here. There we go. Okay. So there is a strike through in terms of the description for laryngoscopy. You'll see that both in number 8 as well as number 10 when we're talking about visualization. So this is to encompass just the increased prevalence of video laryngoscopy and its use throughout the region. I'm sorry, let me decrease this now since Charlie is, there we go. Okay. So the proposed change is to remove the word direct in front of laryngoscopy. So it now will be a more generic term to encompass different modalities to achieve this goal for intubation, as well as for the removal of foreign bodies. Just so that we can make it a little bit less specific, so that we're not encumbering our members to use only just one modality for these methods. I assume like you want to, there's going to be just two protocols that are
Right.
coming forward. So I assume you want to just start the discussion, I assume with this first, and then,
Yeah, I think
Do the
that's a
vote?
good idea.
Okay.
Does anybody have any questions on this? Um, all right, hearing none, let's move on to the next one and we'll just deal with them both
Okay.
together.
no problem. All right, so the next language change that is being proposed is to the GOP section under the definition for CPR, where, as you can see, there is a strike through in terms of the age requirement as to when providers should be using pediatric AED and or monitor pads. Just again, as we're switching to using different types of monitors that may have different minimum requirements, that it is, the language changes now to say according to the manufacturer's directions. So even, for example, for the LifePak 35, it is no longer an age requirement, minimum age requirement, but it's now a weight. I believe it's like less than like 35 pounds in terms of, 35 kilos in terms of when to use the pediatric pads. So that is the proposed language change, is just to remove the age requirement and then to change it to be according to the manufacturer's directions.
Okay, any questions about this? All right, well, hearing none, I think we should keep going and vote on this. Does that sound like a plan?
Nope, these are the only two changes coming forward.
Okay. I think we'll do a roll call for these two language changes. All right,
As written.
as written.
When I call your name, please say if in favor, oppose, or abstain. Bonaceda,
Yes.
Dimitri, Alexis,
Favor.
Dario Gonzalez,
In favor.
Nathan Reisman,
Yeah.
Pamela Lai,
Yes.
Chris Guzak,
Yes.
Doug Isaacs,
In favor.
Jeffrey Raybridge,
Favor.
Jonathan Berkowitz,
Favor.
Lauren Casterico, Michael Redliner,
In favor.
Joseph Schenker,
In favor.
Joseph Bove, Arthur Cooper, Ed Jarvis, Nicholas Vicari, Mark Cantor,
In favor.
Robert Krupe, Laura Evacoli or Stuart Kessler,
In favor.
Bob Hope,
In favor.
Kevin Mangel,
In favor.
Cindy Basilius, Matthew Harris, Mark Hanna, Jessica Van Voorhees, Benjamin Zabar,
In favor.
Paul Barber,
In favor.
Connor Murphy, Eric Blutinger. Motion carries.
Thank you. Anything else? No? Paul?
In regards to these protocols, so now that we have decided that the July 1st implementation date is going to be what we're going to do for 2026. So then will these, first of all, I guess question number one, do these changes need to go to CMAC for approval? And then number two, will these be included into the 2026 July protocols?
So these are language changes. I don't believe that they need to go to CMAC for approval, number one. And again, I think that protocol rollouts and advisories and training packages should be for changes to the protocols, not for clarification languages. I think clarification language is to clarify our intent and of what we've written already. That's what I believe, but that's just one person's opinion. The protocol, whether the protocols have to go to CMAC, Jeff and I agree. So I think that we're good on that. The rest of it is really an opinion of the whole group. Do we feel that an advisory is enough to clarify why we made this language change, or do we want it to wait until July? Daria.
I think a clarification of what Cole's been through is sufficient. Those things change different areas. I would say they don't have to go up there.
They don't have to go to the CMAC, that's for
No.
sure.
No, but he's asking.
The question
do we
is-
Put it out to advisory, or do we do more?
Do we want to wait until July to make this change, or can we put out an advisory that says, listen, we know that you have video laryngoscopes. We wanted to put this out there so you understand that it's
Just
okay to use a video laryngoscope. Well, we can't send it out and then wait until July. But then it would be official now. All right, yeah, I guess we could do that. Yeah.
I mean, I think that should be very clear when you go to the website what the current protocol is. So I'm in favor of saying out advisories, but if we're saying, hey, there are things that are just language changes that are going to go into effect when the advisory goes out, I think the current protocol, the PDF of it, should also get updated at the same time. Because otherwise I think it's too confusing. So if you said, oh, this is going to go into effect in a week from now when the advisor goes out, I think a new version of the PDF of the current protocol should also be updated and be on the website. Otherwise, I would say, whenever the new protocol goes into effect is when things should get, in effect.
Understood. Joe?
So it seems that the purpose of this protocol change is just to do some clarity, answering some questions the paramedics have asked.
Correct.
So what I would recommend, right, because we're going to, again, run into the same issue of constantly trying to change the protocols, is we could put out an advisory clarifying the intent and then just indicate in the advisory that clarification language will be reflected in the July protocol, in the July protocol update. So you don't have to change the protocol. You're just doing it as an FAQ or answering a question, right, that the paramedics have put out there that would pose to the body.
Yeah.
So you're given the clarity, and then you reflect the language changes in the protocol in July.
Yeah, so the issue that, and I'm going to bring this to the table, we're going to have to discuss it, but the protocols in New York City are the standard of care in the region. Legally, they are binding, and we've had cases where people have requested, what was the protocol on such and such a date? So to have any ambiguity is a problem. However, what we're saying right now is that we're taking out the word direct so that people can use a video laryngoscope to do this. And today, if they had a video laryngoscope and would use it, nobody would have a problem with it. You'd be allowed to do it. But we wanted to make clarity so people don't think that they have to use a video laryngoscope and do direct laryngoscopy, because the protocol says, somebody's going to read it and say, it says direct laryngoscopy, so I had to do both. I think that's the intent of what we're trying to do, unless I'm misunderstanding something. So if people are doing this anyway, and we're going to change the protocol, but not change the protocol, we're going to end up with a problem. So I think that if we feel that this is a language change that needs to be made for clarity, because to kind of clarify our intent of the protocols that exist today, we should do that today. Because if we wait, then how are we clarifying what is already going on in the region? Marty, and then Ben, but Marty first.
wouldn't it be like the other protocols that we've done in the past? They would say if available. So if available, they can put that in and that could be the advisor.
But it's already if available. I mean, if you have a video laryngoscope, you can use it. No one says you can't. So all we're saying is that you don't have to do direct laryngoscopy and video. It's a clarification. Ben?
I mean, the way I think of it, and maybe I'm wrong, but that if it's a language change, that just means it doesn't have to go to the state. I think in the past, the group has said, we're not going to constantly roll out new protocols unless it's really important. If it's a tweak or whatever, it'll wait for the next protocol rollout. And I mean, Pam knows better than I do, but I think there's a lot of the things that have already been approved for 2026 that are similar sort of language changes and making clear, yeah, we expect you to remove helmets. You're already doing it. So I think whenever it is, I mean, this seems very similar to the other things that we've changed. And I think it should get implemented with like any other protocol that we're implementing. I think it's releasing immediately is not for small changes to me. It's when it's an emergency that it's life threatening if we don't clarify this thing. So I think this is, if this is approved and we say it doesn't need to go to the state, it should get released with the next protocol, implementation, whenever that is, which it sounds like is 2026, July 1st.
All right, Jeff, and then Mike, and then Pam.
So I think you could do what Ben suggested. You could release it with the protocol, but I think you could also send out an advisory or notice that clarifies that when the protocol, when it says direct laryngoscopy, it means visualization of the airway with either a direct laryngoscope or a video laryngoscope.
That's fine. That makes
And
sense.
then you're keeping the protocols together, but you're also saying, yeah, we realize you're using a VL and this is okay.
Yeah, that I agree.
Mike, and then Pam.
I was going to say something similar, so I won't.
Pam?
Yeah, I was also going to say too, just to a little bit add on to it. I think that we should try to steer away from like having just so many different versions that are potentially going to be running around. It's going to end up causing a lot more confusion if we start doing all of these different advisories that keep going out. And I think that we really should keep, I think like just like what was said before, like with Ben and with others, that big changes, it's going to come out with the one rollout that's going to come out annually. And then otherwise, unless it's for an emergency change.
Okay. So what I'm hearing, and I don't know if Paul.
Just want to also point out how having future thoughts and foresight protocol creation is imperative to avoiding the eventual vernacular changes, as things evolve. So for writing a protocol, let's try not to paint ourselves into a corner for 2027.
Okay. So what I'm hearing is that we want to wait to change the protocol in July, but we should send out an advisory now that clarifies that direct laryngoscopy includes video laryngoscopy, and then we can remove the word direct come July. Does that sound reasonable? Okay, good. What? We're going to do both. Yes, we're going to do what you said. Good. Just so that it can be what Joe said. Next. All right. Anything else, Paul? Please tell me no.
I assume you handled the protocol training update that was part of the protocol committee report in the medical standards minutes.
Yes.
Well, then that concludes the medical standards report that I'm giving on behalf of Dr. Benelli.
So there's one more thing that Dr. Benelli had mentioned that we guess it's under the new business for REMAC, but we'll discuss it now quickly. There was a tag earlier this week to visit rapid sequence intubation in our region. And there was a large discussion at that tag about how do we do, is this something we want to implement? Is this something that is relevant in our region? Is this something that we want to pursue before the tag goes and puts together protocol updates and changes and education and all the different pieces of the puzzle? So I'd like to have a not extensive discussion, but a brief discussion on RSI in the region. Do we think it's something we want to pursue? Do we think it's something that we would be happy if one agency was doing it, but another chooses not to? Would that be good for our region? So if you want, we can have a discussion. There were a lot of training components that would be involved, a lot of re-education, a lot of the skills. I mean, there are a lot of hurdles that you have to get through to do a program like this. And we were kind of on the fence as if it's something that would be implemented after we did all those steps. Any discussion, unless Paul, you want to start the conversation?
No, I actually want to start it by saying thank you to everyone who participated. This is definitely a new endeavor for our region, something that should not be handled lightly. Certainly this is going to be a topic of a lot of opinions and different feedback. So, we wanted to bring back to this group, I guess where we were in our initial components of thinking. And again, this is a structure framework and creation of an ecosystem with both training, credentialing, quality, physician oversight, but it also involves things like procurement, resources, and capital investment that we may, need to understand where that's a feasibility piece. But there was a lot of topics we discussed. I'm very thankful on behalf of the group for Chris Guzak, who was very open about his experience in Suffolk County, and Joe, who's experience in New Jersey. So there was at least some starting points, but our first foray is to really survey the region to see if there's if the work would have merit.
Anyone? Yeah, Dario.
Yeah, I'm not opposed to it, but as I said before, I think it wouldn't be a bad idea to find out where we are at right now. What is the quality of our intubations? Are we 40%, 80%, 20%? I don't know. I do know we see cases of what, and part of it has to do with compliance with capnography. So I would propose, my idea is that we need to know where we're starting from before we go to this.
Okay. Anyone else?
Can I answer that?
Yeah, go ahead.
So Dr. Gonzalez, if we find out that our intubation success rate is 50%, would that engage RSI on a greater level to facilitate a better intubation rate, or would it say that we're not capable of doing intubation at all? I'm just wondering what we do with that.
I'm not going to engage in hypotheticals, but what I am going to say is we don't know where we're starting from. And if we don't know where we're starting from, where are we going? And why are we going there? And I think that we need to know what the basement is. And maybe the answer is that we have to revamp, if you're going to do that, the whole intubation skill. Because remember now, we're not doing as many. The skills that we used to get in the ORs are not being done. We're doing them on cadavers. They're very different. So I think that it's a different era, and we just need to know where we are. And if we don't know where we are, I don't think we should be going there. You can develop a program while you figure out what the base is. And if the base is really bad and it is 50%, we got a problem. The patients have a problem.
So for everyone in the room, a robust training program of both how to and how not to approach an airway with these very dangerous, when used inappropriately, medications, but very successful and represent the standard of care for pre-hospital field intubation. A training program would handle both the relative exclusions as well as the indications. But I would ask the room, how do we get to Dr. Gonzalez's question? Because it's the second time I've heard that exact argument in this room. So how do we get there?
Yeah, Mike.
So currently there's a national airway project that looks at specific quality measures around successful airway management. It includes Airway 01, which is first pass success without hypotension or hypoxia. I think that's a good measure of success of an airway. And we could all decide to measure that for our agencies. And also Airway 18, which is the use of capnography for every airway. So I do think that there's a way to look at it. If we want to look at it before, we would endeavor upon it, and then look at it after, and then say that RSI is a solution to our challenges. Then I think it's it's something that's been done in many places in the country. So I think it's definitely an opportunity. If we want to do a pilot type of program where certain agencies are tasked with looking at it in their own agency, we could do it that way. But I do think we could look at that measure and say, hey, this is where we are with this, and this is where we need, we think we can get with RSI.
Go ahead. Paul?
So Pam, you want to go first? Or?
Sorry, remember.
Just to kind of add on to Michael, like I think it is very admirable, and I think that it is a way that we want to be obviously more data-driven, more evidence-based driven in terms of like how we make our decisions for our region. But I think like even of that, there are a lot of complexities even to try to get those metrics, and I think that those have to be very well and discussed before we can just say like, oh, for the next meeting we can just all present our numbers and what our different agencies have. So even for example, like even like taking a look at the number of attempts, we know that that is not a reliable metric to really kind of put down. Because even for example, like we have in our regions, like we have you can do like what, up to 2 attempts, and then you're supposed to be going to a supraglottic airway. It's like if you take a look at providers from across the board, pretty much you are never going to get an outlier of like over 2, even though I think realistically we all know that other things can happen as opposed to what's actually being documented. The other thing in terms of like taking a look at sort of like your peri-intubation sort of like realm in terms of like blood pressures, looking at peri-intubation, whether or not there's hypoxia or other things, it's complicated because we're taking a look at something that's going to be recorded either post-event or things that where we know like a lot of these timestamps, we're not really getting accurate data. So I think that we do have to be very careful. I think that, we can try to devise a method to be able to better quantify how our region is doing in terms of our intubations and our success rates and everything else. But I think it is a little bit more of a complicated issue than what we might initially think.
Joe?
A big part of what you need to think about is transport time. I'm one of the medical directors of Stony Brook University Hospital, and we use it on the helicopters. We use it on long distance travel. And it took us years to get there. And now we have a very robust program. Transport time in New York City, I don't think is as much. You don't have an hour, you don't have half an hour. Not anymore, right?
About 6.5 minutes across all.
6.5 minutes. You can bag a patient. We're talking about traumas on a highway out in the Hamptons. And we send our helicopter, and it takes X amount of time. And you want that stable airway, put it in a helicopter. So we definitely use it in the helicopter. We do it on ground sometimes, but mostly in the helicopter. It works. When you do it, it works. But the program fully is complicated. And every case is discussed every time. It's something to think about.
And just to, all of these issues were brought up. Oh boy. Transport times were a key part of the discussion, as well as program maintenance, credentialing, decredentialing. We can't even find an applicable system, another large EMS system that's similar to ours. But there's a lot of different representation around this table, and I don't know if this has to be a region-wide launch for it to work. And I would defer intubation success rate to the agency medical directors who are sitting around the room, because they're the ones responsible for training their paramedics and performing their quality. There is no regional quality piece on airway management unless we can launch it. So to start off with an intubation success rate that's region-wide, we don't have the infrastructure, nor has anyone provided the information to make that an actionable item. But more discussion.
John, and then Ben.
Yeah, so there's a great best practices article on this from a couple years ago, and they say pretty clearly with huge caveats that RSI in the right situation is superior to MFI, and I think we have to understand that the alternative is MFI. So even though the transport times are shorter, if we're having a significant amount of MFI and we don't know what the outcomes are, we're not doing the residents of New York City a favor if we're not looking at that and then determining what to do. Now, I'll tell you that RSI is developing an RSI program as described is incredibly difficult, at minimum 5 years, probably longer. here, maybe 50. But I think that it's worth it, and it really does go hand in hand with increasing VL. We do 100% review of every VL that's automatically recorded. It shows a lot of the things that Pam mentioned that aren't maybe not in the PCR, and we learn a lot. But it really is. If some of this is a fact of that the PCR data versus the real data don't correlate, and as Dario said, that the monitor data is also really important. But this is a journey that we should embark on improving pre-hospital airway management. It does start with the data and understanding the data, but we shouldn't be afraid to lean into RSI. But we should do it with strength, with data, and with commitment.
Ben?
Yeah. I mean, I would agree. And I think we know that there's patients, clenched jaws and so on, who, even in New York City would potentially benefit from a paralytic. But it is a big burden. And I sort of what Paul was saying, which he described well, the training, the QI, both internal and potentially at the regional level. And we've had discussion about, would CRITE be required? Would video be required? How many years of training or how many years of experience do you need to be credentialed to do this? So I don't think we're quite at the point to sort of ask people to stand up and say, yes, we personally want to do this. But I think we're going to get to the point where this effort's going to stall out unless there's medical directors who say, for our agency, assuming, even when it's not fully worked out, assuming it's something similar to Suffolk and similar reporting requirements and training requirements, that our agency wants to do RSI. And so I think people should start having those discussions internally. I know we I'm not saying that for our agency yet, but I think, there's only so much work that's going to go into this if nobody's doing it. Everything else that's happened in the region where things have been pushed forward, whether it's CPAP or BLS IGL or whatever, it's because an agency has said, we want to do this. So I think people should just start thinking about, if it was similar to, say, Suffolk or some of these other RSI programs, would you want to do it in New York City for your agency? Because sooner or later, someone's going to have to say yes. Otherwise, it's not going to happen.
Yeah, I think we're all saying something similar. I think we all agree that, RSI is the ideal standard of care in airway management. However, right, the devil's in the details, and there's a lot that goes with these programs, right? If you look at other regions, it's 100% QI of every case. Some agencies, it's, you have to record the laryngoscopy. It is a lot of work for the medical directors. I'm not saying we shouldn't do it, but I think we need to go into it knowing that there's a lot to be done. It's not that simple. And even ongoing, right? Like, yeah, you could approve them, credential them for that, but there's ongoing training and retraining, right? And making sure they maintain that schizoperishable skill. Like Dario said, we're not doing as many, intubations in the field these days. So it's certainly something to consider. I think we should continue to talk about it and talk about, where it may make sense and how we kind of want to design it.
So in our discussion, Chris was very specific about the iteration and the growth and the maturation. So Joe, exactly what you both, whatever which you had said, we were very fortunate that Chris gave us a lot of that feedback. And, I think an equivalent immediacy is just farcical, right? So since we have a need to drive agency interest, since we have a need to drive data, and since we have a need or desire to drive a framework, I'm going to make a motion that all ALS agencies submit monthly quality airway data to the REMAC Quality Committee. And I would defer to quality leaders in the room, such as Mike and Lauren, et cetera, on what that looks like. But I would at least start with number of attempts, number of end tidal, yes, no, backup devices required, number of airways, and focus on training afterwards. And that way, we can drive who's interested. We can drive a regional understanding of airway management, and we can also drive the beginning of a framework.
So before there's anybody who's second, let me just explain. The region, part of the agreement for ALS agencies with the REMAC is that they have to submit to QA. The QA committee can define what they want to evaluate from QA. So there's no reason to make a motion to send that. The QA committee can just determine that this is the QA initiative we want to look at, and send that out to everybody. I'm not sure that we need a motion for that, but that can be done at the QA committee. If you want to make the motion and somebody wants to second it, we can do that and vote on it, but that is the purpose of the QA committee.
I can't believe you out Roberts me.
They, by definite, they are required to submit it to maintain their ALS agency status. They don't all do it, but that's what they are required to do. And we don't, if they're not submitting and they're not participating in QA, we cannot renew their ALS status when it comes up. Well,
Oh, good. Sorry. We do have an ongoing airway safety project within the quality committee right now. I don't know if folks remember, we presented some of that data maybe like 6 months to a year ago. But I think that it's tough for us to be the first line quality process because, you know, we have a lot of data. We're looking at the important data that, you know, Pam and Michael are talking about, peri-intubation hypoxia, hypotension, but we don't necessarily have the resources to look at all that data from across the region. We did have a summer intern come in and try to help with this, but I think it's not sustainable for us to be first line. It's going to have to take a lot of work on the parts of agency medical directors to be involved. So that's why I would probably support it not being mandatory, or at least that being part of a discussion to assess interest.
yeah, go ahead, Chris.
Yeah, and the only other thing I would say is that, you know, while I agree and know it, like seeing kind of what our current standard is important, it's not quite an apples to apples comparison because you're talking about so much more extensive training on airway management, when to do something, when not to do something. So like looking at something right now, which is basically like if the person needs an airway, put an airway in, versus we're doing an RSI and there's all this emphasis on, you know, pre-intubation resuscitation and strategies of airway management and the decision making that goes into it. You know, I think the standard is going to be so much higher after you do this type of education that I don't want to say where we are right now doesn't really matter, but it kind of doesn't matter because we're going to be in a completely different place after we get through an RSI program.
Right.
I would almost approach it a little bit different. I think that you have to frame the, so first of all, I think the gold standard data for airway management is really in the monitor. It's in the monitor data. And you're going to find out the vital signs, the real, you know, kind of first pass success, the real end tidal CO2. I think that, right, I think we should hold ourselves to that standard because I do think that that's how you really know if an airway was successful or unsuccessful. So, and I would take a little bit of a different approach, which is I think we should create a goal, you know, kind of like the minimal standard or a credentialing process related to airway management. So if you wanted to even go down the RSI pathway, then you would have to do that standard. And again, I think we can develop the standard pretty quickly. And I think we could do some test cases of agencies that are wanting to do that, to understand where they are, so that if they would decide that they want to do an RSI program, they would be able to have a good, strong base to go from.
All right, I think we've heard a lot of discussion on this. I think we have to, let's continue this at the RSI tag. If anybody's interested in participating, please let us know, and we will move forward with that. Okay, I think that's it, right? Oh. Yes. Okay, sorry, can't see. All right, Dr. Kosterko, the QA/QI report.
Okay. So the Quality Committee met September 29th. We reviewed 2 course sponsorship applications for Brooklyn College and NYU. It was decided more information was needed to fully assess the applications. So committee members are touching base with representatives from each organization to learn a little bit more about the programs, and we'll continue to discuss those internally. Now that everybody has had an opportunity to train on the First Watch regional platform, we're going to start to send feedback on 2 metrics to EMS agencies. We're going to send BGL for stroke and aspirin administration for STEMI. So your agency may receive some feedback from us on these measures. Our goal is just to elevate patient care here in the region. So please just let us know how we can continue to support that. And I will end on this very high note. On October 15th, we held an NAEMSP Quality and Safety course here in the city. This is an excellent course. You've probably all heard of it, that normally requires traveling to one of the EMS conferences to attend, but this was made available to our providers locally at a very affordable cost. First, I want to thank Joe Ranieri for all of his hard work coordinating. And secondly, I want to thank Mike Redlener, who not only was the brains behind the idea and played a huge role in coordinating, but also was one of the teachers. We also had 2 other amazing leaders in EMS quality come give the course, Maya Dorset and Mike Tagman. They flew from around the country, so that was greatly generous of them. The course went really well. We had attendees from all over the region, and I think this will have a really positive impact on the quality of care to our patients. So thanks to everybody. And next meeting time is TBD. Please answer Michelle's survey on the most convenient times that work for you if you're part of the committee.
Doug?
Thanks, Lauren, for the update. Question regarding First Watch. I know it's become a very useful tool as we've got more comfortable using it. What about how we're going to continue funding for this program? Because I believe the contract has come to an end, and there's a cost to region. So prior to that was the American Heart Association to provide that funding. So are there any plans how to fund it moving forward?
That's a great question. Don't know the answer.
That's a great question, Doug. That's something that the offices of the council take a look at and see if we can track down some funding to, continue to support this great program. Unfortunately, I was not in the position I am in now, so I'm not too familiar with the contracting side of First Watch, but I will reach out to them and see where we're at and try to do our due diligence, get some funding for it, and hopefully get additional funding to expand the dashboard as well.
Yeah, the big cost was initially the setup. So every year it's come down, the average cost. So hopefully it won't be as favorable. So
Do you know when it officially ends, the funding?
things been over, but they just been extending it.
Anything else for Dr. Caserta? No? Okay. Dr. Berkowitz, interfacility.
So as discussed last time, hopefully folks have had a chance to review it. And I've got a lot of very nice feedback, open to the nasty feedback, but definitely want the feedback. So anyone, kind of just make it open forum for folks that have reviewed it with comments about it. I will note that there's also a state tag on a similar topic. So I am hoping that we can have a vote at this meeting to share with the state what we think are the minimum standards for safe interfacility transport.
So this was, at the last meeting, we asked everyone to look at this, give feedback, both positive, negative. There was no significant feedback. So at this point, I think we will vote on the current interfacility guidelines as they are written to be added to our regional protocols as guidelines for the management of interfacility patients. And that's how we'll call them. We're going to call them interfacility guidelines.
I'd like to make a comment.
Yes.
I'm sorry I didn't get to, I thought they were gonna mail out new ones, but I did review it today. And I still have concerns about us establishing standards for something that I really don't know much about. I think that's a concern. I know that the guidelines are not mandatory, but within that document, there are protocols that are including the use of telemetry, requiring telemetry trained physicians to be able to handle that. That's going to be a separate system that's going to be outside of it. So I would feel uncomfortable telling somebody else who does in the facility how to manage what they do. I still think it's separation of Article 28 and 30. I think that we're overstepping. Nothing else.
Just a minor comment. The one place in the document that says that residents can't it says that residents, excuse me, cannot be the provider on the interfacility transport. And in another place it says an unlicensed provider can't be, and then in parentheses it says resident. And those are not mutually exclusive. You get your license after internship. So whichever one it should be both.
Thanks, Nate. I would say unlicensed is the appropriate one unless anyone disagrees.
Yeah, I don't know much about interfacility. I don't know if residents are helpful or useful or if you're using them for that. So whichever one it is, it just should be consistent.
Okay. Any other comments? I mean, I think that unlicensed residents are generally either, I mean, you don't have to be licensed to be a resident until you graduate, but if you are going to get a license, it has to be after your intern year. I would say that most interns are not very helpful in the pre-hospital setting when it comes to these transports. Most of the time, the people that are helpful and that go on these transports are fellows who are specifically going as part of the transport response, which is appropriate. And those are usually licensed. But I think that the correct terminology should be licensed rather than resident of any particular year. And we can make that change later. Any other, Michael?
I mean, it's an informational question. I think that the Article 28 versus Article 30 is an interesting one. I don't know the answer to it. And then I guess the second piece is, like, what's the pathway from here? It goes, this would be kind of our regional guidelines, and then it goes to the state for discussion, or it just is a regional guideline?
So it would be a regional guideline. I know that there is a concurrent discussion going on at the state. They could look at our guidelines and they could say, oh, you know, these are the guidelines from New York City. The way it would be presented at the state, because we probably should let them know, is these are the guidelines that we have released for New York City, rather than saying, are these okay? Because we're not asked if it's not a protocol, we're not asking for them to approve anything. We are presenting it for their awareness.
So then I would ask what the purpose of having this is as a standard for the region for all of our interfacility transport colleagues who do this work every day. This is but I don't know if there's any enforceability versus not. I mean, I guess the question is, right, where does that end? I like the idea of having this. I think it's very well written. I think we should have something that's a mark, but I'm not sure what the enforceability is.
So I agree with you. I don't think we have the full answer to that. We have to get legal involved to figure out what the enforceability is. I do think that these minimal standards are important, and we should look into what the enforceability is. So right now, though, there are guidelines that are released to the region to say, look, this is what we believe as physicians, as a group, is what you should be doing, the minimal standard. If it gets to the point where we find legal counsel that will say that this is enforceable, then I think we should enforce it. But I think it's just having it out as a guidance for ambulance for services that do this is important in and of itself. Anyone else? All right, so hearing no more discussion,
I'm sorry. So,
yeah, I would say, yeah. I mean, I would think that we're saying that regionally they should have certain standards. Correct. 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 Well, again, if Lands the company. Yeah, anyone who's doing an interfacility transport should follow these guidelines. Right now, they're just guidelines. We don't know that they're enforceable yet. So right now it's just a guideline, but they should be following them. That's my opinion. Obviously, we're all gonna vote. Everybody can have their own opinion.
Yeah, just to kind of give, I just want to give a little coloring, because again, it's just remember, these are minimum standards, so a lot of it is what the agency should do to make sure it's safe. So if, let's say, we vote on this and hopefully pass it, and in 2 weeks, a medic comes to you and says, my other job, I do interfacility, I've never touched an A line before, I've never had to manage Clevipex before, and they put me in the back of an ambulance, titrating this medication I've never used, using the A line I've never used. That's the kind of thing that we're trying to prevent. And there's no protocols in this document, but it says if you're going to put someone in the back of an ambulance with the paramedic, that it's the agency's responsibility to train them, to do quality. These are baseline stuff. This is not. There's no actually prescription of any care in terms of Jerry, you mentioned protocols. The only description of protocols on there is that the agency should have protocols for the common conditions that they treat. So if an agency moves a lot of OB patients, well, they probably should have a protocol for that. If they move a lot of patients with a stroke, then they probably should have protocols for that too. But if they don't move any of those patients, then they don't need a protocol for that, because it's not prescriptive of the care, it's prescriptive of the system that they should set up to deliver the care.
Yeah.
I just, from a metric perspective, I think it creates a comfort for agencies that then have to pick up a pediatric patient, transfer them, let's say, to a tertiary children's hospital, who don't normally transport children, to know that.
You got to hold the button.
Sorry, forgive me. I didn't want the reverb to hit. I think it offers a bit of comfort to agencies that are asked for interfacility transport as a result of mutual aid, when dedicated interfacility transport teams are taxed and we don't have available units. I just want to narrow the scope of my comment to the pediatric point, because we are finding now at Morgan Stanley that our interfacility transport teams are far more frequently having to outsource interfacility transport teams, and having a minimum set of standards or guidelines for agencies to be aware of, I think, is a wonderful thing. And I just wanted to say that.
Okay. Any other comments? All right, hearing none, because this is limited to a guideline, we will just do a hand vote to see to approve this, unless you guys want to do a roll call just for formality purposes. I think we can just do a hand vote. Okay, so Dario would like it because you want it, Dario. No problem. Okay. It's not a motion. It's to pass the inter-facility guidelines and add them as a document in the region.
All right, so it's to pass the interfacility guidelines and add them as a document in the region.
Correct. Yeah.
Legal aspect first before voting, so we know what we're voting on and what's going to happen with it.
Well, the legal aspect is to define whether or not we can enforce this. Right now, we're passing guidelines that we believe are what is the safe minimal standards in the region. No, it's not enforceable right now, right? And not as far as we know. Yes.
Why signing on to the document that states legal should look at it and let you know what you are signing on to. And that's why I want it by roll call, so that we can say yes or no.
Understood.
But I think there's the rush to actually get it out. I think it's not.
Well,
right.
I would
You
say
don't
it's
need
not
to-
rushed though.
No.
This
it
was
is
written
rushed.
over 2 years.
And so what? We do things over 3 years.
Ah.
But the idea is that you want to know now, when we haven't really looked at that piece. And I think that legal should look at it. I think there are other issues down the road that'll happen. Not gonna debate it, but I'm just telling you my opinion.
Understood.
Right, Brent?
John?
Yeah, just in terms of like the legality, in terms of what the state thinks. I mean, the state actually has formed an official interfacility committee as well. Clearly the state believes that there is some precedent for bodies like ours in Article 30 to opine on this matter. There's a lot of grayness. I don't disagree with that, but it's not like that. It's not like that. This is out of left field, so to speak.
Paul, did you have a comment?
Just want to, can you hear me okay, Charlie? Kevin doesn't like it when people say, speaking to the mic. This was not rushed. This has been like the length of a congressional tour of duty in Washington. This is like a 2 or 3 year item. So if we want to read the documents, let's read the documents. If we want to discuss the documents, let's discuss the documents. But I think this has had its day. And Dr. Berkowitz's knowledge of interfacility medicine and transfer medicine and how the state and credentialing interacts is unparalleled. I urge all of you that this is good for our region and good for patients that we take care of.
All right, so we'll do this as a roll call. When you hear your name, please say yes or no.
Melina Seda. Dimitri Alexis.
In favor.
Dario Gonzalez.
No.
Nathan Reisman. Pamela Lai.
Abstain.
Christopher Guzak.
Yes.
Doug Isaacs. Jeffrey Raybridge.
Yeah.
Jonathan Berkowitz. Lauren Casterco. Michael Redliner.
In favor.
Joseph Schenker.
In favor.
Joseph Bowe. Arthur Cooper. Ed Jarvis, Nicholas Piccari. Mark Cantor.
In favor.
Robert Krupe.
In favor.
Stuart Kessler.
Favor.
Bob Hope.
In favor.
Kevin Manjal.
In favor.
Cindy Basilios.
In favor.
Matthew Harris. Or Mark Hanna.
In favor.
Jessica Van Voorhees. Benjamin Zabar.
Favor.
Paul Barber.
In favor.
Connor Murphy. Harry Buttinger.
There were 19 votes in favor, 1 vote against, and 4 abstentions. The motion or the guidelines will be added to our protocol. Thank you, everyone who worked on this. I think that this will definitely help agencies and providers in our region. Okay, anything else, Dr. Berkowitz? Okay, regional council update, Dr. Krupe.
Thank you so much. So the Regional Emergency Services Council, New York City, met on September 30th at Riverside Drive. Approved motions, okay, approved by ballot, the election of Dr. Constantine Caritan and Steve Peloso, okay, JD, to serve as at-large members of the Regional EMS Council, New York City for 4 terms, commencing July 1st, 2025, and concluding June 30th, 2029. Approved nomination for myself, okay, as REMSCO, New York City REMSCO representative to the State EMS Council, okay, for my term ending December 2026. Approved Grace Catchall's reappointment as FIDE representative, added Lieutenant Kenny Chung as secondary representative with Deputy Chief Mario Tompkins as alternate. Approved the Gator reappointment of Dr. Joseph Schenker as the REMAC representative to the Regional Council with Dr. David Benelli as the alternate. Approve the endorsement of a precise operating territory for the Roxbury Volunteer Fire Department, defined as Rockaway Peninsula west of Beach 146th Street in Queens, New York. Emergency Preparedness Update. The Office of the Regional Council staff is collaborating with the Queensborough Emergency Preparedness Coalition to implement an EMS well first responder mental health symposium scheduled for late May. Once the date, location are finalized, more information will be available. This will actually be the second one I think we collaborated on. Last year was actually a very big success. The Office of the Regional Council updating its internal systems to assist with streamlining processes for REMAC and online medical control credentialing. More information will be available at the next Regional Council meeting. Program agency update. The Regional Council continues to operate under the 5-year program agency agreement that runs from July 1st, 2024 to June 30, 2029, administered in 1-year operational periods. The fiscal 2025 contract has been received, and the fiscal year 2026 budget request has been submitted to the Department of Health. Payments for previous fiscal years remain outstanding, however. Vouchers are processed quarterly with payment within 30 days of approval. Annual funding allocations include $50,000 for recruitment and retention initiatives, $20,000 for the Dr. Pizza Paramedic Scholarship Program. This scholarship program will continue for year 2026. We have applications scheduled to open in January or February of next year. The program agency is providing technical assistance to small regional program agencies, accounting delays in the state contracting process, offering administrative guidance and compliance support. In addition, the office is developing information materials for the CUNY Reconnect program to expand awareness of tuition-free paramedic education opportunities, complementing existing recruitment and scholarships efforts across the region. Training education, the committee reviewed the 2026 regional protocols and confirmed that the changes are minimal and primarily language clarifications, as we discussed earlier. These revisions will be distributed to the LMS as a text-based update package by late October or early November. The committee identified a recurring issue in the onboarding of newly certified EMTs with paramedic orientation procedures. With local credentialing requirements. Additionally, new onboarding modules will be developed and made available through the learning management system and REMSCO website. The legislative committee is conducting a detailed review of Article 30 with attention to New York City-specific EMS needs. The committee discussed the need to expand membership on the recruitment and retention tag. EMS agencies were encouraged to nominate personnel with expertise in recruitment and retention or grant writing to support the group's efforts. You want me to report on it? Yes. Okay, so I think we got any questions about anything I just mentioned?
I don't have it.
Okay.
Anyone? Nothing? All right, thank you. Okay, there was no REMSCO CMAC. There will be, the next meeting is in December, I believe. All right. The unfinished business, we have the STEMI tag, Dr. Isaacs.
Sure, we're just waiting to confirm the date from Greater New York Hospital Association. They are very generous to supplying the facility. So Andrew's here, but we're hoping by end of November, early December. So we already have a draft letter that's going to go out to participants, cardiologists, emergency medicine physician, of course, anyone on the committee. And Joe, you'll review that as well. And we'll get that out as soon as possible. There are a few centers, cardiologists, we may not have contact information, so I'll be reaching out to a few of you.
Any questions for Dr. Isaacs? All right, finally, the patient destination. Sorry, go ahead, Laura.
Sorry, I didn't hear all of that. So this upcoming meeting in November, December, you want to include cardiologists?
Yeah, so that's what we started at the beginning, that, you know, we want to include all the stakeholders. At the end of the day, they're the ones who perform the procedures. So when we initially did this, started in 2007, when we did establish the STEMI program in New York City. We included all the stakeholders. So yes, we plan on including them. It's going to be hard to have in-person meeting all the time, but we thought as a first meeting in person was important. And after that, we'll establish if we need working groups or what have you, that can be done virtually.
Finally, the patient destination tag met earlier today. There has, with the change to the protocol, with 3 hospitals now listed in CAD and 15 minutes as a time, there's definitely been significant improvement. I don't think the region has gotten any complaints or concerns of late. There was a discussion as to trying to define medically complex, not as a definition per se, but as guidelines for what providers should be looking at for medical complexity. What are the things that they should be considering? It was stated that the region itself does not have the ability to dictate the operational guidelines of any agency, but we can give direction to the crews to help them understand what they should be looking for, when they should be thinking about making a phone call and contacting online medical control. That is going to be worked on. If anybody has any input to that, please let us know. Just email the office and it will be included in the definition. The next meeting is to be determined. Any other new business other than what we discussed already? Yes.
This is really more REMSCO and ambulance committee, but just to let everybody aware, if they haven't seen it on the news, Northwell is pulling 6 ambulance tours out of the 911 system effective November 15th, 3 of which are in Manhattan, 2 are in Queens, and 1 in Staten Island.
Thank you. Yeah, Dr. Pastrico.
In relation to the operational changes, I know we touched on this a few meetings ago about potentially informing the public of these changes so they can be more knowledgeable about what calling 911 means. Can we talk about that more?
Sure. What do you want to say?
Well, sorry, it was a few meetings ago. No, I think that it would be making this change patients because expectations might not be met, but I think to kind of educate them ahead of time is important.
Mm-hmm. That's a great question. I don't know what the right avenue would be to inform patients of this change. But I think that is definitely something that we should consider. Any other comments about that? Any other thoughts on that? Anybody have any thoughts on how we best?
The FDNY is creating PSAs. I know they're creating videos. I'm not sure how soon they're going to be released, but there are PSAs being created.
Yeah,
Go ahead.
Yes, you do.
No, and just to Lauren's point, I mean, I think it's great that the fire department's creating PSA. I don't know. It's almost like to explain to the public, okay, you used to be able to go 10 minutes past the closest hospital and now you can go 15 minutes from the scene. And, is that intelligible to a patient in terms of well, can I go to more hospitals or less hospitals where I live? I think it's great to inform people. I don't exactly know what we're trying to tell them.
Yeah, I hear that. I think maybe just the idea that when you call 911, you might not get to go to your hospital of choice if it's a, dangerous emergency.
Doug?
Just to Chief Cashel, the public service announcements that the department's been putting together, they've already released one of them, I know. So that's part of that educating the public about the use of 911 system for emergencies.
I believe that's the one in the Bronx. The one in the Bronx has been circulated.
I'm just thinking it could help both empower our patients and operationally if the goal is to, have shorter response times, having a patient call and then a crew stuck on scene because the patient refuses transport. It's not good for really anybody.
Okay. That's it, I think. Any other new business? Oh, right. Okay, so one other thing, I didn't want to do this, but we have to. We have to reappoint Dr. Ravitch to our CMAC seat. So Dr. Ravitch represents this body at CMAC. So all in favor of reappointing Dr. Ravitch to CMAC, please raise your hand.
Stay.
2 abstentions, all right. Anyone opposed? Anyone opposed? Joe? Okay. All right, and the motion passes. Thank you, and continue to represent us, and, what's that?
Is it legitimately opposed?
Yes, no, it wasn't, he abstained, he didn't really abstain. Okay, I'll entertain motion to adjourn in second. All right, thank you all very much. The next meeting is sometime.